Welcome everyone to the fourth, I think, Monash Partners Consumer and Community Involvement lunchtime seminar. We're really thrilled that you could join us all today. Today we've got a really interesting presentation. I think it'll be stimulating and hopefully we'll have some really great discussion. We've got Dr. Rhonda Garad joining us. Rhonda's a Senior Lecturer and Research Fellow in the Monash Centre for Health Research and Implementation. Before we begin, I wanted to acknowledge the traditional owners of the land on which we're meeting today and pay my respects to elders past, present and emerging. In the spirit of reconciliation, I extend my respects to any Aboriginal and Torres Strait Islander people joining us today. Wherever you are, I acknowledge and pay respects to our First People. I know many of you are joining us have been on previous webinars with us, but this is a part of a regular lunchtime seminar series where we seek to bring you stimulating presentations that highlight some of the principles and practices around consumer and community involvement. Our purpose at Monash Partners is to connect researchers, healthcare professionals, consumers to innovate for better health for our community. We really want to learn from each other. Please ask questions throughout the chat while the webinar is in progress. We'll be monitoring the chat and there'll be plenty of opportunity at the end of the session for us to have a discussion around those. Just to let you know, today's seminar is being audio and video recorded, and we'll also save the chat, and in a few days' time you can expect to receive a newsletter from us with an update of the summary of the key points, and we'll also make a recording of the webinar available through the Monash Partners website for you to view as well. So our format today is a presentation by Rhonda, and I'll hand over in a minute, and then a reflection, some key questions that we'll just ask Rhonda to respond to, and then we'll open it up for discussions and from everybody joining us today. Just a reminder as we're going along, please feed your questions into the chat. We'll be monitoring it. If you have any technical issues, we do have Sarah Carmody and Victoria on standby, and we look forward to hearing your thoughts. So introducing Rhonda, Dr. Rhonda Garad is a Senior Lecturer and Research Fellow in the Monash Centre for Health Research and Implementation within Monash University. Rhonda's work is in public health, and she has a lot of experience in translation of research into practice and focused on the implementation of research outcomes. She has a strong focus on influencing systems change and the orientation of care to meet the needs of end users. Her PhD was in the field of health literacy, and she is a key lead on a Monash Master's Program in Implementation Science. Rhonda, thank you. We're delighted to have you with us today. Looking forward to hearing your presentation, and I will now hand over to you.
Thank you so much. So let me just pull up my slides. And just hoping everybody can see that. Nope.
We can see it, but you're in screen. We can see your notes.
Yeah. Okay. Display sets.
Yeah.
Presenter view.
Yeah.
Beautiful. All right. So thank you so much. Thank you so much for the invitation to speak today. I couldn't resist when I was asked to speak. I couldn't resist because I found the topic so intriguing. Navigating power imbalances in consumer and community involvement is something that I'm a little bit obsessed about, and so I was so pleased to be asked to speak about it today. So my name is Rhonda Garad. As mentioned, I work at the Monash Centre for Health Research and Implementation, and I work mostly in education and research translation. So we've come to an interesting place, I think, in health services. So we've come to a time when contemporary health policies require consumers to be involved in all stages of health service planning, implementation, delivery and evaluation. And I find that interesting because I am old enough to remember a time when consumers had no input in health services. So I was a nurse. I became a nurse about 1,000 years ago. And when I first started nursing, we literally stood at the end of a patient's bed and never ever spoke to a patient. We never said their name. The doctors and nurses would simply stand at the end of the bed and make decisions about the patient without ever asking anything about the patient. So I have seen that, and now it seems to me we've come to a wonderful place where now we see the involvement of consumers as a requirement, certainly at a policy level. So I think we've come to a fantastic place. We've almost come to a place, in fact, where CCI is almost spoken about in hushed and kind of reverential terms. So, you know, CCI has become enshrined as an important pillar of health services and empirical research, including roles during stages of research, development, design. So we're using words such as enshrined and pillars of health services. So, you know, we are so respectful and we are so enamoured of this process that we're using these wonderful terms. And I don't think there would be any one of us that here today would have a problem or would challenge the idea that consumers should inherently be involved in having a say in the health services. It's such an implicitly good idea. It's a bit like mother's milk. It's something that is such a good idea, and you kind of wonder how we ever existed without it. And there's been a lot of work. So, you know, overseas organisations have a bit more evolved, if you like, along this path. And Involve, the UK-based one, is one of the best. And so they've developed things such as values and principles around CCI. And they talk about things such as respect, where researchers and consumers are respectful of one another's roles and perspectives, where the public have access to practical and organisational support. So that's a right of theirs. We talk about the public having clear and open aims and scope of involvement. We talk about responsiveness to the input of public members, and we talk about fairness of opportunity and accountability. So we have come a long way in building frameworks, values, principles that all underpin this fantastic idea about consumer involvement. And in fact, this movement has evolved out of a human rights framework and mostly from the disability sector. So we have brought all those inherent values into our current contemporary understanding of CCI, which is wonderful. And as I say, such a great idea. We've even developed a range of frameworks so we can understand levels of participation. The IAP2 is probably one of the best known ones. So we can even articulate, what level of involvement consumers can have. So we go all the way from informed, where we just keep people informed, which is probably the most common level of involvement, right up to empowerment, where we say, we'll actually do what you tell us to do. So we have developed a really, really finessed lexicon of terms around consumer involvement. So this is from, a standard from the Australian Commission on Safety and Quality. And they talk about concepts such as co-planning, co-designing, co-delivering, co-evaluating. So we have this very nuanced language, and we understand that there are stages and levels of engagement. And co implies we're all in this journey together, and we're happily moving through this partnership kind of process in this kind of utopian environment, if you like, of participation, consumer participation. So what could possibly go wrong? It's a great idea. We've thought about it. We've got some lovely frameworks. So how could this possibly go wrong? So just for the sake of today, actually just before that, I will talk a little bit about my experience and what I'm basing my experience on today. So at MICRI, we have 3 CREs, so we have 3 Centres of Research Excellence. This one is in women's health and in reproductive life, and in that we develop guidelines, clinical guidelines. Mostly our guidelines around a condition called polycystic ovarian syndrome, but we're also developing other guidelines around infertility and early menopause. And so we've been doing that for about a decade, and across that time we've developed a roadmap, if you like, or a process for how we at MICRI approach CCI. And we have developed a process where we embed consumer involvement across the whole ecosystem of research and research translation. So consumers are involved in our formative research. So for our guidelines, we have up to 3,000 consumers having input, identifying system gaps, telling us what is wrong with the system, helping us understand where we need to go in how we need to reshape systems. They actively input into prioritising research questions. They actively input into what we call guideline development groups, which is where a lot of the negotiation happens around recommendations for clinical work. And they're very actively involved in research translation. So how we move research out into the world, we very much appreciate and incorporate their involvement in doing that. So they're involved in every part of the research and translation ecosystem. And we very much come from a values base, and our values base is well encapsulated in this quote from our head of unit, Professor Helena Teed, where she talks about the communities are funders and beneficiaries of healthcare, the health and medical research, where we're all the collective custodians of our health and research systems. And we must work together through research and healthcare improvement to shape our health systems to best serve our community. So what she has done and what we do at MICRI is actually place the consumer right at the centre of what we do, and always with an eye to everything we develop and involves the consumer for the end benefit of the consumer. So it's very much an ethical approach, and very much around, this is why we're here to benefit the consumer, and everything we do must follow from that. And we have developed, some principles and rationales. I won't go into them in detail, but just to say they're very much values-based and very much embedded in the concepts of equity and really a underpinning of human rights. All right, so now we get to the fun bit. This is the slightly controversial bit, and this is the bit where I hope you will all take me on and challenge me a little bit. So this is not evidence-based, this is purely my observations over the decade or so that I have been working in this space. And I'm kind of interested to know whether you agree or disagree with some of what I think are our inherent or sort of implicit or unspoken assumptions that can really cause a problem in developing an effective consumer involvement system. So I believe that some of the problems we have is that we call our consumers, and the implication in the word consumer is that they are customers. So we have this word, and this word implies that the people coming to our health systems are just like customers. So they're buying our services, they're participating in our services, and therefore the implication is that they are inherently powerful. So as consumers, we have money and we go and buy goods or services, and we can dictate exactly what we want and how that should be done, because we're very clear on what we want, and we have this fairly equal level of power. And I would argue that's not the case. And I know there's a lot of people that have a real problem with the word consumer. But the problem with the word consumer is that there's not necessarily a better word to replace it. And we know the word patient has a range of problems as well. But one of the problems is if we assume that consumers have all the skills and the power they need to come to us and ask for what they want in a consumer involvement environment, then we're assuming an equal power balance. And I would argue that's very much not the case. That in fact, patients coming to a health service are very powerless, and they don't know necessarily what they want or what they need, and therefore it is wrong of us to assume that they have that level of health literacy or that level of skill or that level of understanding. My number 2 idea is that consultation or community involvement is based in a quasi-marketing concept around consumer involvement. And the problem with that is that it's often decoupled from values. So when we talk about having a customer focus, we're really talking about a concept that is decoupled from values. So it's not steeped in equity. It's not steeped in a values-based, in which I believe healthcare should be. And so there is a troubling decoupling, if you like, of this concept of a consumer involvement, which is just about power and not necessarily about inherent values. Number 3 is we assume that patients or consumers have a desire to participate. And there's almost this kind of illness debt. If you have an illness, if you have a condition, there is this kind of obligation on your part to be involved in some kind of consumer participation. And Tricia Greenhalgh, who is one of my favourite people of all time, puts this well, where she says, it is a truth universally acknowledged by policymakers, researchers and research funding bodies that patients and the public should be involved. So there is this kind of implication that an obligation almost, that patients will be happy to be involved, and that in fact they should. It's kind of the debt they owe us, because as health professionals we try and look after them, and therefore they should participate. And that's not necessarily always the case. Sorry, I'm just getting back to my slide. So point number 4 is around how much capability we as health professionals have to be part of a consultation or an involvement process. So often we act as though we do have those skills, and it's kind of interesting because, as clinicians or healthcare workers, we're very good at a lot of things. We're very good at diagnosing, we're very good at caring for patients. But what is it about our background or our skills that makes us think that we have the skills to be a capable member of a CCI process? That the idea that we just, because we're health professionals and because we're capable beings, that we actually have this skill set. And these skills involved in CCI are incredibly broad. You need really high level negotiation skills. You need really, really high, you need the ability to understand how to devolve power and have an inclusive communication process. These are not necessarily skills any of us are taught in our training, and not necessarily skills we actually have. So we often work on the basis as health professionals that we have these skills. And in fact, do we? Do we really have the skills required? The point number 5 is around representation, and this is always a tricky idea. Is representation really effectively possible? So, for example, Monash Health is one of the biggest health providers in the southeast and has one of the most diverse communities within it. Is it really possible for us to clearly represent all of the diverse groups within our consumer base and really clearly have their voice at the table in a CCI process? And I'm just throwing this up to be controversial, and I'm hoping you will refute that or come back at me with and challenging that. But I just put it out there that, you know, it is one of those concepts that we think if we have one or two consumers sitting at a table, that they're necessarily representative. So I'm just kind of challenging the idea around what really is representative. Is it possible? And if it's not possible, you know, what are some of the compromises around that? So my point number 6 is a common language. We assume that when we're all sitting around the table that we have a common language. And I would sincerely challenge that. In my experience, as health professionals, as researchers, as active workers within a health system, we have our own jargon, we have our own lexicon, but most importantly, we have a very different perspective. So we talk about patients or consumers as kind of an otherness, you know, that group outside us, and we take a very objective perspective, and the language we use and the way we talk about patients is very objectified, and it's very much around an external group, external to us. Whereas the language used by consumers is very much around a narrative, personalised experience. So it's often emotionally laced, and it's often very much around, you know, this was my experience. You know, this is what I want to tell you about my experience of being in the health system. And those two types of approaches are often polar opposites. And there can be conflict, inherent conflict, when neither party recognises that the language is so far from each other. So this can become quite a problem when consumers might become upset when they're objectified, when their experience is objectified. And conversely, health practitioners can become irritated when consumers use an individualised experience when health professionals are talking about everybody's experience. So language differences can become a point of conflict in a poorly managed or a poorly structured CCI process. And then there's the idea that we have the structures in place. There's the idea that we have the resources in place, that we have resources to train up consumers, that we have the funds available to create job descriptions, to provide adequate training, that we have the skills in our workforce, that we have the time and the space and all of the things that are required for an effective CCI process within a health system. And rarely do we actually have that. Often CCI is something that's kind of tagged on, and it's often assumed a lot of people give free time, that consumers may give their time freely, that even health professionals do it in their own time. So, you know, the idea that we actually have systems in place to accommodate and allow a CCI process to flourish is often not the case. And number 8, you know, it's often said, it's a bit like privilege. Often health professionals say that there is no power imbalance, that we're all sitting around the table and we're all, you know, we all have equal power and we all have, you know, an equal stake and status in that environment. But it's often true, you know, we talk about privilege. The only people that often don't see privilege are the people that actually have it. And as health professionals, we have a lot of power. We have the power of language, we have the power of knowledge, we have the power of status. And so therefore, we are so endowed with power that we rarely see it. And so we enjoy the luxury of power, and we assume that that power is that everybody has access to that same level of power. So often we'll say, well, there's no power differential. There's no power imbalance, which is one of the most problematic things we can do. And my last one is that as health professionals, you know, inherently, we often value our opinion over the opinion of consumers. We may not say that, and we may try very hard to overcome that that bias, but inherently we may have that bias based on years of study, based on years of experience, and based on, you know, a whole range of things. And the problem with that is that we may not listen very well. And if we listen, we may not actually take on board what consumers are telling us. It's often very instructive to listen to a meeting and just to see how much airtime consumers actually get in a meeting. And it's actually often very little. And if they do speak, they're often spoken over, or they're not spoken to. And so we have some of those the behaviours which indicate that we may not value consumers' perspectives as much as we value health professionals' perspectives. So there you are. They're my 9 controversial, inherent, implicit assumptions. And I'm so hopeful that people will take me on. Now, I will just talk about what I believe are the remedies to some of those implicit assumptions. I would argue that in the context of CCI, consumers are not customers, and we must not treat them as such. So therefore, we must not treat them as having all the power and skills that customers generally have in a marketing kind of environment. That we must always couple our CCI endeavours with values, that CCI is inherently embedded in the values of equity and equality and human rights, and that we must always stay true to those ethical values in what we do. That consumers are not inherently obliged to be part of our CCI process, and that in fact we're asking a lot of them, that asking consumers to come along and be in a patient, be only seen in one context as a patient is asking a lot of them, and actually that can be quite it can be quite a difficult thing for them to do. And I think we need to recognise actually what we're asking them to do. And it's a lot. And so we must just recognise that, you know, we need to acknowledge that what we're asking to do is quite heroic, in fact, often. And we must pay homage to that. That health professionals may not inherently have the skills to negotiate a CCI process, but in fact they must deliberately go out and build those skills. And as a system, we must provide those avenues, and I know that Monash Partners do have a module around building skills around CCI, but it is a deliberate process around building those skills, that they are not inherent skills that health professionals have, that skills of negotiation, the skills of clear and deliberate consultation are really, really specialised skills, and we don't necessarily just have those. That representation is possible, but it needs to be constantly challenged and reviewed. That we constantly need to assess who are our users and how well does our CCI process reflect our users. So it's a dynamic process, it's a constantly changing process, and it's an active process on the part of healthcare professionals to make sure they actually have representative people sitting around the table. That we develop a common language. And it is my experience that we actually need brokers in the room, that in a CCI process, we actually need people who are skilled to bring the language of the consumers and health professionals together. And that is quite a skilled brokering role. And you need somebody who has is very experienced at doing that and can move easily between these different objective and subjective worlds. That we do have the structures and resources in place. And so you know, and I know that Monash partners have gone a long way down this path, but we do need to acknowledge that this takes resources in a myriad of ways, and that it is inherent in organisations not to have a tokenistic approach, but to actually have layered and well-resourced structures in place for skilling people up and for having a robust CCI process. And we must acknowledge that there is an inherent power imbalance. Just recognising that, just taking steps to accommodate and make sure that you know, we are inclusive and we are devolving power, and what that means and how you do that, really, really important. And again, that's about building capacity around that. And my final point, so we must learn, you know, to genuinely respect the perspective of consumers and make sure that our behaviour reflects that in a CCI environment. And again, that takes skills and that takes training. So just to say that you are really lucky having Monash partners that have developed a really, really comprehensive process around CCI that you are all able to access. As I said, there's a learning module there, and then there's a whole range of resources that have been developed that you can access. So I'm going to stop talking there, and I'm hoping that people will come in and perhaps give me a bit of a hard time. Happy to hear about your experiences, any comments you make, challenge me in any way. I just want to say that photo probably has nothing to do with questions, but I just loved it so much that I popped it in there. So I'm very happy for people to start asking questions.
Great, Rhonda. Thanks so much. It's so fascinating and really interesting food for thought. And even just like the whole thing of like holding space for consumers. Often in the space, we don't know that we're talking over and not giving enough airtime. And I know I was in the Q&A audience recently, and they said that the facilitator, the host, gets the minutes people are talking for each of the panel members, so he can distribute responses appropriately if someone is talking too much. And I was just like, oh, you almost need that person sitting on the balcony saying, you are talking too much, need to like free up some time. Before we open up to questions, and there are a few questions for you in the chat that Sarah will bring to your attention shortly, but we have 3 quick rapid fire questions for you. And we ask this of all of our presenters. So our first one is, what has been one of your key learnings from your consumer and community involvement work to date?
One of my key learnings is that I am a victim. I'm going to say a victim. I am an outcome, if you like, of my experiences. So I have been, I was apprenticed into the health system at the age of 19, and a product of my environment is what I want to say. And therefore, I have all the blinkers and the biases that health system has imbued me with. And so I understand that I need to articulate, recognise, and put, you know, deliberately overcome those biases. So I understand my limitations, and I understand I need to actively overcome them.
Amazing. Great. And what has been either the best or worst advice you have heard about CCI?
Look, you know, there's inherently that kind of, what makes my skin crawl is that kind of patronising language where we talk about, you know, people, you know, good people coming along and sharing their stories, and, you know, what nice, there's kind of this head patting thing around consumers, and, you know, how lovely they are, and how nice it all is. And rather than seeing these people as really strong, articulate people who are brave enough to come and tell us their stories, which takes courage, and they should be respected equally. I feel like there's this patronising attitude often, and it really makes my skin crawl. And so it's not advice per se, but it's kind of an attitude that I really feel we need to weed out.
Yeah, very good point. Just reflecting, we often come away from meetings and go, oh, our consumers were so lovely and great, but there's very rarely, though, I come across other meetings where we walk out and make that comment.
Exactly.
So good point.
Yeah.
And final question, what would better look like in an ideal world? What would better look like for consumer and community involvement in health and medical research and healthcare improvement?
Yeah, what would better look like? So in an ideal world, you know, we would see them as an inherent. I was listening to a health consumer the other day speaking, and this question was put to her, and her response was really fascinating. She just said, my great hope is it's just normalized. You know, that consumer involvement is as normalised as health professional involvement, that we're consulted in the same way, with the same reverence, we're valued as much as health professionals, that it's just this really normal process.
Yeah, great. That's a really great response. Okay, so we're going to open it up to questions. A reminder, you can put questions in the chat as Rhonda's replying to a few. Now, Sarah, we have had a few questions. Did you want to go through them for Rhonda?
Yeah, thank you, Dash, and thank you very much, Rhonda. We have a question that's come through from John, which is in the Q&A, and also thank you for the great presentation.
Thanks, John.
The question is, regarding consumers are customers, which can be powerful, why not using the person-centered care concept, implying that knowing the consumer patient as a person, not just as another patient or clinical requirement?
Yeah, John, look, I think you've just answered that ideal world question. In an ideal world, we would see them as that, and certainly, you know, a person-centered approach is exactly what we're talking about here. I guess what I would say, and I guess my point of my talk was really around, you know, at a policy level, we believe this. At a framework level, we believe this. I often think that it's the implementation, you know, where we actually fall down. And so whilst we try for a person-centered approach, and certainly, you know, that's absolutely the right approach, you know, I just sometimes wonder about our ability to actually deliver on that. And unless we see past our biases and our assumptions, I just don't think we can. And so I absolutely take your point. It's certainly the perfect approach. And if you do that well, then hats off to you. And I do think the younger generation of health professionals coming through do that better than somebody who's as old as I am. But it's just, I just want us to be really critical of ourselves and really look critically at what we do and what we say, and the difference between what we say we do and what we actually do. So, yeah, a patient-centered approach, absolutely, if we do it well.
Thank you, Rhonda. And we've got another, perhaps not a question, but a comment that came through from Louise. And this was back to the area you're talking about, language, Rhonda, and Louise's comment was that the English language doesn't offer the right language for this sort of stuff, but she likes the experts by experience, and sort of nothing is perfect.
Yeah, good question. I need to give that some thought. That's a really good point. Yeah, language has limitations, and our point about what we actually call them. You know, we're limited. Are they consumers? Are they patients? Are they customers? Are they, you know, all that kind of what is implied in a name, and what language really perfectly explains what we're saying. So yeah, I agree. Language is limited. I'd be interested to know if other people, you know, are there other languages that could do this better? I'm not sure. But I think that, yeah, we need to keep striving for the right words. But I agree with you, experts by experience. I love that. I love that whole idea. I love the whole idea of you know, the narrative experience, the first person experience as teacher to us all. So yeah, all I can say is I agree. Language is limited, and sometimes it limits us.
Thank you. And now I think I've captured all the questions in the chat. Let me know, Dash, if I've missed any. But we've got some questions as well that the Monash Partners team wanted to raise with you, Rhonda, and have a discussion on. And the first one of those is, perhaps for people working in this space and wanting to become really aware that perhaps there is a power imbalance. I know you've talked a bit about this, but what are some of the signs and the symptoms we can be looking for to navigate around that?
Yeah, look, such a great question. Who asked that? You know, well done, whoever that was. It's such an interesting question, but I think that you're talking about language before, and sometimes our language is very telling. And if we're using different language when we describe consumers as we would to health professionals, you know, the language which implies authority, you know, language that implies power imbalances, and there are key words that we use. And those kind of patronising words that we talked about before about, you know, how lovely and how sweet and how nice patients are. And we use those kind of patronising terms that minimise the value that we're giving to consumers. That's often very telling. But also, you know, things like who's talking, who's sitting at the head of the table, who's being the dominant forces in the room, how often do we speak. Also, I think that I just wanted to tell you about an experience that I had last week, and it's a little bit it was a little bit disturbing, but it's also about, you know, how we sometimes just forget about consumers in the room. But last week we had a international meeting of a steering group full of international experts, and our 2 consumers were part of that, which was great, and they're great consumers, and it was all great. And then the health professionals started to get a little bit carried away by some new research, and they were a little excited, and they started to discuss it. And they said things like, okay, so we've discovered there's a new process that is causing some of these conditions, and we've also discovered that this condition these consumers had is associated with early dementia. So we've just made a link between this condition and early dementia. And we're all very excited by that, and we're like, oh, isn't that fascinating, you know? And we're deeply involved in the intellectualness of that, and very detached from that emotionally. And then one of the consumers jumped in and said, oh my God, my mother has early dementia, I have this condition, therefore I'm probably going to get early dementia, aren't I? And every one of us just froze, because we realised how insensitive we had been, and we realised that, you know, that was just, it was us just tripping off an hour of power, intellectual, you know, kind of objective, kind of detached thing, and just not recognised how emotionally involved these consumers were. So that's a little tangential to the question you asked, but I just wanted to raise that as an example of just how mindful and careful we need to be in being inclusive, and what inclusive really means.
Thank you for sharing that, Rhonda. That's a fantastic example about how this work, it's a lot of it is the subtle things and the conversations that are had, and where people are sitting at the table, and all of those sorts of things. So it's big things and small things.
Yes, absolutely.
So next question that the Monash Partners team had that we wanted to ask you about was, from the consumer side of things, like obviously there's a whole range of things that we can be doing at a systems level and as health professionals, but from a consumer side and perspective, what sort of things can consumers be doing to try and address the imbalances when they're seeing things from their end?
Yeah, great question. And can I call on Dash to also back me up on this one, because Dash has actually probably got more expertise in this field than me. What I would say to that is that we need to give the patients or the consumers the right to call it out. You know, that they need to be, you know, part of having an inclusive experience is setting the boundaries. And I think that what we need to do with consumers at the very onset is say, you can call out any behaviour you find, you know, is belittling or non-inclusive, or whatever the boundaries you give to that. You know, you need to keep calling us out on that, and we need to keep taking that on board and responding. But in other ways, they need to be trained up. They need to be participating in training. They need to have a job description. They need to be paid. They need to have all the accoutrement, if you like, of value, what we value, and that's the way we value things. We give people a name, we give them status, we give them money. And so they have a right to all that. So participate in all that. But also, you know, they need to be given permission to call things out. But I'd just like to ask Dash what her thoughts are on that, because I'd be interested to hear.
I totally agree with that. Giving permission and saying that's actually what we want from you and that we want to learn from you. And so we can't learn and we're not going to know what we're doing well or what we're not doing well if we don't get that feedback. But I would also say having pre-briefing and debriefing sessions with your consumers is really helpful, because sometimes it might not be in the moment that they feel like they can say it, or they might not have had. And I know this even when I sit in meetings, sometimes things are said and I'm like, whoa, that was awful, but I haven't had the chance to gather my thoughts quickly enough to call it out, but to kind of give opportunities. And I was sitting in a group with health professionals and consumers, and some of our health professionals kept using the term demented. So instead of saying someone who is living with dementia, they were saying, oh, this person's demented. And the carer in that group very quietly afterwards told me about that. And I said, look, we've really got to watch our language again in how we're using that. So yeah. It's really important.
Yeah, great point. I think that, you know, even briefing, pre and post briefing takes time and resources too, and skills, you know, so it is about, you know, if you're going to do this well, do it to the nth degree.
Yeah.
Thank you both. Okay, so we've got a question, a comment and a question here from Joanne in the chat, so I'll read that out to you. We often refer to bringing the expertise of a lived experience. Your point about health professional capability is the key. So the question is here, if consumers are considered as bringing a diverse perspective, common language is required to build a working relationship. What are your thoughts on this?
And you know, my thoughts are that's a big ask. My thoughts are, you know, that's a really big ask. They're already bringing so much. They're bringing their time, their experience, you know, and their courage. And you know, a common language, what does that mean? Health professionals, we have our own jargon. You know, we're deeply steeped in jargon, so much so that even when you ask us to translate words, we often can't because we're so steeped in this jargon that we don't actually have easily. I work in translation, where I try and make inaccessible language accessible, and it's extremely hard. It's one of the hardest things. I think it was Winston Churchill that said, I would write you a shorter letter, but I don't have time. You know, writing simple, plain language is really hard, and health professionals are just the worst at it. And I don't think we have the skills to do that, and then we can't ask the consumer to suddenly understand all that jargon. That's why I think a broker is so necessary. I think a broker in that situation, and somebody that can break down the jargon, that somebody can elevate a narrative to, you know, a point that the health professionals might engage with it. Those skills of a broker, in my opinion, are incredibly important, and you really need that person in that environment, just so that you decrease conflict, you de-escalate conflict, because you can often get you know, conflict in those environments, but also you get shared understanding. So in my opinion, you have to have an intervening person in there.
Thank you, Rhonda. That's fabulous. Now we've got just a comment here from Louise, and she's just popped in the chat about the Dementia Australia's Dementia Language Guidelines. So I guess there are some resources that we can use to help those conversations. So really great. Thank you for sharing, Louise.
Thank you. I mean, some organisations have done fantastic work in the space, so I just want to acknowledge them. You know, there are consumer groups that have done fantastic work. So I'm taking the worst possible scenario just to be controversial today, but just to acknowledge that some groups have done extraordinary work and do this incredibly well. So, you know, just to acknowledge all that as well.
Thank you. Now we've got one other question that the Monash Partners team really wanted to ask you about, Rhonda, and that was, in considering consumer involvement and the consumers that we currently work with, what about those people who currently aren't at the table? What should we be thinking and doing and planning? How can we work in that space?
Yeah, and it's a truism that the people that are not there are the people we actually need most. So, and we all struggle with that, and I can see Angela nodding furiously there. This is the one we all struggle with, all I can say is it's really, really hard. We need outreach. You know, we need to actually go and actively engage. First of all, we need to map who's not there. We need that mapping process. So we need to know who's not there, and that's not easy. So you need to start matching, you know, databases of patient show-ups with who's not sitting around that table. That's a process. And then you need to have deliberative processes to go out and actively seek those people and entice them. You know, and again, that's about resources, isn't it? And we're often so limited in our resources. But in an ideal world, that's what we would do. We would actively map them, identify them, go out there and, you know, develop a range of ways. One of the things we're doing now in polycystic ovarian syndrome is that rather than having face-to-face meetings, which are problematic because you can only get the people that are localized, you can only get people that can actively come, you can only get people that, you know, have the ability to drive and blah blah blah. So we have an app. We've developed an app for this condition. That's the first evidence-based app that has been developed, and now we're using that app. So we have currently 8,000 users of that app, and it's growing every day. So we are putting invitations through that app to be active consumers and give us active feedback. So we get them from across Australia, and we will never see them face to face, and we offer them a range of ways to interact with us, whichever suits them. And those that have language barriers, you know, we want them to, you know, just communicate with us in whatever way, in images or in just send us a short video, whatever is more accessible. So we're not saying to them, this is how you have to communicate with us. We're saying you communicate with us in any way that you feel comfortable. So it's a bit of a shifting away from, you know, you have to write us a screed and you have to da-da-da-da. We're just saying whatever works for you, we want to hear that. So, you know, being very flexible and open to different ways of doing things, I think, is a really important approach. And therefore we can reach some of those people that we'll never have around the table, but whose opinions and whose experiences are just so important.
What a great approach. Thank you. Now, I can't see any more questions coming in on the chat, but perhaps I might throw it back to Dash and Angela if you've got some questions or wanted to wrap up statements. Meredith
actually just asked, how do people become aware of the app?
Yeah, so I'm just going to put the web address for the app. It's actually a web-based app, so you can actually get it through Google, and it's called askpcos.org, pretty sure. So just put that into Google and you'll find it. So it's a free app, and it's fabulous. And if I don't say so myself, but yeah, that's the way we're developing a communication system, and I think that's a way of the future. I think that we, with CCI, we need to get more digitally savvy around it and provide a number of ways that people can give us feedback and input that doesn't involve driving somewhere and sitting around a table.
Love it. Good. Angela, did you want to finish up and wrap up?
Absolutely. Completely agree, Rhonda. I think COVID has forced us to think very differently about things and how we engage. And I think doing a lot of things across online platforms has created opportunities for consumers to be involved in perhaps other ways, perhaps they wouldn't have before, but I think we need to keep our focus on that. And I think the focus on flexibility is really, really important, and thinking about creating multiple channels and ways for consumers to engage is really, really important. I wanted to thank you most sincerely for your time today. I've really enjoyed hearing your presentation. It's been thought-provoking and really stimulating. I think there's lots for us to take away as a Monash Partners Consumer and Community Involvement team as we progress the activities under this platform. I'd like to thank everybody for attending today. We really value your engagement in the activities that we're leading. Please be in touch with us if you think that if you have ideas about things that would be useful. We're always really interested to hear them. Our contact email address is in the chat there, and Sarah might pop it in. Sarah's also just going to pop in a link to a very, very brief Qualtrics survey, which would only take about 2 to 3 minutes. We're really committed to growing this program and to hearing feedback around how we can make things better. So any suggestions that you have via the survey or via a quick email would be really greatly appreciated. And we thank you so much. Our seminar next for the month of June, we will be having a panel of consumers joining us, and we'll have a discussion with them about consumer and community involvement from their perspective. I think it'll be an invaluable opportunity to hear about their insights, what works well, where are the opportunities for us to do this better than we do now. So Sarah's popped the Monash Partners CCI address in there, and the survey will pop up when you exit out of Zoom. And Rhonda, once again, thanks to Sarah.
It's been my great pleasure. Thank you so much for the invitation, and thanks for what you do. It's fantastic. And
we'll look forward to seeing you all again next month. Thank you so much.
All right, so I have to. Okay.
That's good.
I'm going through madly.
It's such a good presentation. Hang on.